I had the opportunity at ASCO 2018 to talk about the escalation and escalation of therapy in patients with HER2 positive breast cancer in the adjuvant setting. In this session, we review some clinical aspects of patients with early stage breast cancer that it's HER2 positive, emphasizing all the advances that we've made in the last decade, improving the outcomes of these patients, highlighting the importance of trastuzumab as a key component in the treatment of our patients. Something that we're facing as a challenge right now is a group of patients that, despite this great therapy, still relapse. And that forces us to trying to optimize our regimens and try to identify the patients that we can escalate in treatment and separate them from those that we can de-escalate therapies. So in this talk, I've really divided the strategies to escalate therapy and the strategies to de-escalate. The key strategy right now to escalate treatment, it's adding new molecules. Today, we have access to two new drugs that have been approved by the FDA in the last year, pertuzumab and neratinib. Pertuzumab, it's a humanized monoclonal antibody that has showed incredible success and great efficacy in the metastatic setting. And the affinity trial, a large adjuvant trial that evaluated the role of pertuzumab in this patient population, showed at 4 years an increase in disease-free survival of 1.7%. And that led to the approval of pertuzumab in the adjuvant setting. Neratinib, it's an oral molecule, easy administration, it's a tyrosine kinase inhibitor, and this molecule has actually modest activity in the metastatic setting. In early stage breast cancer, it was evaluated in the Extenet clinical trial. Patients that had completed trastuzumab-based chemotherapy were then randomized to receive this molecule or placebo. And what this trial demonstrated was at about a 2.3% improvement in disease-free survival. And this drug also got approved by the FDA. So in both cases, these drugs are now available, but as clinicians, we are facing the challenge of identifying who are the patients that benefit from this drug, since the improvements in outcomes are relatively small. We still don't have mature data in terms of overall survival. So we're very likely going to start using these drugs in patients that are high risk. The ASCO adjuvant guidelines for management of patients with breast cancers were updated last week. I invite you all to read this document. I had the privilege to be part of this panel. And the recommendation from the ASCO guideline panel was that we may use these molecules in patients that are high risk, of course, encouraging clinicians to engage in shared decision-making process. These drugs make indeed our treatments more complex, make them longer, makes them more expensive and more toxic, since these molecules are associated with important toxicities, particularly neratinib in the pivotal clinical trial was associated with important rates of diarrhea. So that's one strategy that we have. Another strategy is try to identify patients that are higher risk, meaning those that have residual disease after neoadjuvant chemotherapy and their clinical trials ongoing, targeting this population. Now, talking briefly about the escalation of care, the key or one of the groups where we can really evaluate this approach, it's those patients that tend to have better outcomes, and therefore we may not need to give them a very toxic regimen. So we're trying to identify regimens that are less toxic. Right now, it's standard practice in patients with no negative tumors to use combinations like weekly paclitaxel in combination with trastuzumab as suggested by the ATP trial led by the Dana-Farber group. We are looking into less toxic regimens, for example, evaluating the role of TDM1 in this patient population. Another very relevant question in terms of the escalation of care is the duration of trastuzumab-based therapy. Traditionally, we've used 1 year of adjuvant trastuzumab in these patients, but the question of duration continues to be relevant. There's going to be data presented at this meeting that it's going to be key to maybe identify patients that could benefit or could have equivalent outcomes with shorter regimens. And the question of duration is going to be particularly relevant in the future as we have the doublet agents. Maybe if we have two agents, we can do shorter regimens. So it's an area that it's evolving rapidly. The algorithms are going to continue to change. We hopefully will have effective and practical biomarkers in the future to identify the patients that need more treatment, so that way we can give them the therapies that they need and spare the toxicities to other patients. And hopefully we're going to truly engage our patients in a shared decision-making process, so we can inform them of the benefits that sometimes can be minimal and the sometimes not so minimal side effects, but again, hopefully with the end goal of improving our patients' outcomes.